Hi, everyone, and welcome to ABCs of Anesthesia. And today I'm going to go through another worst case scenario session with Dr. Ralph. Now, with these worst case scenarios, I literally get people to these really brave doctors like Dr. Ralph who are sitting their final exams, and I pretty much put them in scenarios as close to the exam as I think is possible, which is giving them a scenario that's really quite complicated, has a lot of tricky decision making, and we just pretty much flow through a patient's journey, just throwing as many dilemmas and difficult issues and testing the doctor's knowledge. And this is often what happens in especially the ANSCA exam, but Ralph is also going through the Hong Kong version of the Anesthesiology exam. So welcome, Ralph. How's it going?
Yeah, good. I think I just have to throw myself into the deep end to test the water, really. Thanks for doing this for me.
No problems at all. And I think a lot of people who get to listen to this and kind of take lessons from our conversation really benefit from it. So that's great. And we'll get started. Now, what I'm going to do is I'm going to put up a stem for 90 seconds. And after that, I'm actually going to read it out and then I'll start answering this question. So first of all, I'm just going to share the screen. Can you see that okay?
Yeah.
Beautiful. So I'm just going to read it out for everyone who's listening on the podcast. A 13-year-old male presents to the emergency department in a small rural hospital. So it's small because there's 2 theaters, 1 ward, no HD or ICU, with right iliac fossa abdominal pain. They've got a past history of Duchenne's muscular dystrophy. They're wheelchair bound, severe scoliosis, and they're about 50 kilograms on a recent weight. The vital signs are 110 in sinus rhythm, blood pressure 100 on 70, sats on 95% on 2 liters nasal pulmonary oxygen, respiratory rate's 40, temperature's 37.4, bloods FB is 120, white cell count 13, which is elevated, platelets 400, which is elevated. And the surgeon is concerned about a ruptured appendix and would like to urgently go to theatre for a laparoscopic appendicectomy. His father is very concerned about the anaesthetic. And your question is, what is Duchenne's muscular dystrophy and what are the concerning aspects of this disease for the anaesthetic? And I'll now start your 90 seconds. Candidate 1, 2, 3, do you understand the question?
Yes, I do.
Excellent. So please tell me, what is Duchenne muscular dystrophy and what are the concerning aspects of this disease for the anaesthetic?
So Duchenne muscular dystrophy is an X-linked recessive disease that is primarily a neuromuscular disorder. It's the lack of dystrophin contributed to the pathophysiology of the patients, characterized by progressive muscle weakness. They also have features of pseudo-hypertrophy. Usually, they have a shorter than normal life expectancy, and other complications would include cardiomyopathy and respiratory failure.
What do you mean by pseudo-hypertrophy?
So, because of the lack of the dystrophin, they are not able to build up muscle fiber. So these muscle fibers are replaced by fibrous tissue. So in terms of the actual bulk itself, more of it is connective tissue rather than muscle fiber.
Okay. What do you know about the disease progression?
So they present usually in the first decade of life. Usually, like this patient we discussed, they are immobile, wheelchair-bound by the second decade. Most of it will progress, have some sort of cardiorespiratory complication by the second or third decade of life. There is a variant known as the Becker's muscular dystrophy, which is more or less like a milder version of Duchenne muscular dystrophy.
Okay. Now, you mentioned cardiac issues. So what are the relevant issues on anesthetic?
So they usually present with a cardiomyopathy or conduction defects. So in terms of the anesthetic implication, if I were to see this patient as a routine pre-op, then I'll focus on the cardiorespiratory function in my history taking, such as the signs and symptoms of cardiac failure, respiratory failure, whether they have any functional symptoms. In our case, he's wheelchair bound, which means that he's not able to perform even function of daily life independently. So in this case, it's very high risk.
Okay, so you mentioned there's cardiac. Out of the cardiac issues, what's most concerning to you about this patient for the anesthetic?
Would be cardiomyopathy. Aside the cardiomyopathy, of course, is the muscle disease. So they have in terms of the anesthetic, they're prone to there's the link of malignant hypothermia and also anesthesia-related rhabdomyolysis, both of which has big anesthetic implications.
Yeah, okay. Anything else from a cardiac point of view that's very significant for anesthesia?
Conduction abnormalities.
Anything else?
Any congenital heart disease or structural heart disease, such as atrial septal defects or ventricular septal defects.
Do they have that? Is that increased?
There is associated with it, but they're not so much increased.
You mentioned MH. Is this at risk of MH?
It's a bit controversial because from what I know, they do have sort of MH-like symptoms,
What do you mean?
but they have there's some signs of sort of masseter spasms, hypothermia, and also rhabdomyolysis, but they might not be sort of a whole full-blown MH. So that's why they have a different sort of separate entity known as anesthesia-related rhabdomyolysis.
Okay. And you mentioned the respiratory problems with this disease. What does that encompass from an anesthetic point of view?
So again, it depends. It kind of reflected by the functional symptoms, and also we can have a look at if they have any respiratory function test done pre-op. So if they have a FVC less than 50% predicted, that means they have a high risk of having the needing respiratory support post-op, such as non-invasive ventilation, CPAP. Certainly, if the FVC less than 30%, then they will most certainly need post-op mechanical ventilation because of the impaired respiratory mechanics and because of the pre-op status.
Anything else?
They have higher risk of aspiration, especially if they have bulbar involvement. So in terms of the anesthetic implication, then this is very important, especially in this patient, this emergency unfasted patient, combining with the fact that it's got Duchenne muscular dystrophy and the aspiration risk is even higher. So intraoperatively and perioperatively, the aspiration risk is very high. And if they suffer an aspiration pneumonia as a result of that, then the risk of mortality would be much higher than a normal patient.
Just to pick you up on something else, so are you saying that this patient, like they've got an appendicitis, are they at more risk intraoperatively of aspiration than another patient with appendicitis?
If they have intraoperatively, if they have a secured airway, not. But when we're thinking about whether to extubate him straight away, so immediately post extubation, they would be at a higher risk of aspiration. Okay.
Any other aspects of the disease that affect their ventilation and respiration?
Yeah, I think the obviously the muscle itself, the respiratory muscle itself, and also the actual natural history of the disease also affect the anesthetic. So this patient's already in this first decade of life, so he might have the disease for some years.
You mentioned FVC being, like if the vital capacity FVC is low, what does that tell you? What kind of disease is this?
If the FVC is low, that means just the FVC is low. That means it's a muscular disease.
Yeah, and what kind of lung disease would that be? I think you're about to say it.
Obstructive, because of the scoliosis. Sorry, restrictive lung disease.
Yeah, good. So it's restrictive lung disease because of the
scoliosis. Yeah.
Okay, good.
Yeah.
Okay, so imagine this patient again. You, 13-year-old. They've come for the lap appendicectomy. What do you make of this presentation? I can remind you of the bloods and vital signs already in the chat.
Sure.
Feel free to go ahead.
Yeah, so this is a young patient with a severe neuromuscular disease in a rural hospital with no ICU support. He's also have signs of sepsis, as evident by the tachycardia and the raised white cell in the initial blood workup.
That's good. So I'm not sure if I asked this, but so what do you want to know on assessment?
So on my pre-op assessment of this patient, aside from my usual anesthetic assessment, I would focus on the current respiratory and cardiovascular function or symptoms that he has, especially focusing on whether he's adequately resuscitated from the sepsis perspective. given he's got a suspected ruptured appendix. So we'll do a rapid airway assessment because he may need rapid airway support if he further deteriorate and the background muscular dystrophy, Duchenne muscular dystrophy. Also give him oxygen to ensure, I think you already given me a saturation, which is okay.
Yeah, 95
on two. Yeah. So if by the time if I go down some signs of decompensation, they might consider giving him higher oxygen. So I'll concentrate also on the respiratory rate, just to see whether, I think you already give him is 40, which is very high. So he's actually had a higher work of breathing, so he will need some oxygen, respiratory support. I might consider starting him on some CPAP, even down in the emergency department, just to reduce his work of breathing a little bit, giving him a bit of PEEP with the CPAP. Going to see, I'll ensure he's got two wide bore IV access, assess how much fluid's been given down in the emergency department. We'll give him another bolus of 1 liter of normal saline, just to adequately ensure his preload is adequate. And also assess the general GCS.
Tell me more about C. What else do you want to know about?
Okay, so I also want to have a look at a 12-lead ECG, just to see what the underlying rhythm is, any other underlying.
To let you know, it's sinus tachy and PR prolongation present, but otherwise no abnormalities.
Not any limited history, I suppose, but I will ask for any previous follow-up in the hospital.
What else do you want to know about the resuscitation stat of this patient?
Whether he's got on any vasopressor support, whether he's got given any antibiotics from the sepsis perspective, any blood culture has been taken, and fluid already mentioned. We give him a bolus, type in screen whether it's done.
How much fluid did you give this patient?
I'll give him a liter stat straight away, and then reassess whether that improve his tachycardia or improve his blood pressure. Also concerned about the respiratory, like I mentioned, because the respiratory is very high, but I try to temporize it with giving him some non-invasive ventilation. Okay.
So let's say this patient does have an art line and two large bore cannula, let's say 16 gauge on both sides. You're able actually one 16 gauge on the left side in the cubital fossa. Doesn't have very good venous access. So they're lucky to get that. Heart rate is, in spite of, let's say, a total of 2 liters of resuscitation, heart rate's 130, still in sinus rhythm, with occasional atrial ectopics, just very occasional, one every minute or so. Blood pressure is 90 on 50. The sats are still 95% on 2 liters. Respiratory rate still 40, and you have instituted CPAP. Hasn't made a difference to the rest rate. The temperature is 37.8. They have been started on broad spectrum antibiotics, as recommended by the surgeon. So they've had ceftriaxone, metronidazole, and given paracetamol as well. Now you're in this center. What do you want to do for here? Do you want to do the operation here? Or do you want to transfer?
It's a difficult decision for him because he's currently not responding to the resuscitation. In fact, his hemodynamic status is worse than before. And also the respiratory signs are not telling me that he's improving. This is probably because of the worsening sepsis and the fact that he's had limited reserve, given the background of sepsis, complicated by the fact that he's presented in a rural hospital with no ICU support. I think transferring him outside of this hospital will also have a high risk as well, i.e. You will have to ensure he's got a secured airway on mechanical ventilation, on inotropic support en route to another place. That will depend on how far that is, I suppose. But even say half an hour to an hour is still a significant risk if I were to put him on an ambulance or an escort transfer.
And let's say it's a 30-minute ambulance ride, just to give you context, to the tertiary hospital nearby. Keep going.
So I think this would be a multidisciplinary decision with the surgeon, myself.
Let's say, definitely true. You talk to everyone. Let's say you're the resuscitation and expert on the overall hemodynamics of the patient. It's up to you. What do you want to do? The surgeon's happy.
In this case, I think what I would do is to prefer to have the operation done in this hospital, but to transfer him to a hospital with a ICU support post-operatively, with a secured airway and inotropic support. The reason being is because I can secure his airway, put in a central line, start him on the inotropic support, and then the surgeon can gain rapid sepsis control with performing a appendicectomy. Okay. Obviously, we can't keep this patient in this hospital after the operation, but we should be able to perform the operation here.
Sounds good. So let's say you choose to do the operation there, and you've got all the resources you need. Even in spite of being a small hospital, it has all the equipment that you need for this operation and for the anesthetic safely. So you immediately arrive to theatre at your hospital, and you prepare for your anesthetic. So how do you prepare for this anesthetic, and what are you going to do for it?
So my goals here in this Duchenne muscular dystrophy patient with ruptured appendix is to because of the prone to malignant hypothermia and or anesthetic related rhabdomyolysis, I will avoid agents that will precipitate those two complications. But obviously the difficult decision is that he's got an aspiration risk as well, given he's got ruptured appendix. So my choice of induction method would be a rapid sequence induction with fentanyl. So 50 kilos, I'll give him 100 mics of fentanyl. Because of the hemodynamic status, I'll give him 1 milligram of midazolam followed by 50 milligrams of propofol as a modified RSI, just to be very careful with his induction status. He's got an outline in situ, so I'll run some phenylephrine or metaraminol infusion while I put him under anesthesia, followed by a 1.5 milligram per kilo rocuronium with sugammadex as sort of drawn up as a reverse already. After the induction and secure the airway, I would change to TIVA to avoid any sort of risk of rhabdomyolysis or malignant hypothermia. So the implications of that will have it will impact the contractility of his heart quite a lot, given the dose of the propofol and the remifentanil that he needed for the TCI, and for the TIVA. So I will need to put in a central line after induction. So start him on some noradrenaline during the maintenance. The ventilation is going to not be that.
So you avoided sucks, obviously, for this risk of anesthesia-related rhabdo. What dose of muscle relaxant do you generally need for these patients?
It's usually a reduced dose. Usually.
What was the dose you gave?
I think I could give you a normal dose of 1.5 milligram do the.
When do you ever give 1.5 per kilo of rocuronium? Is that? I've never heard of that dose.
Okay. So I think it's 1 milligram usually per kilo for the rocuronium for rapid sequence induction. For him, I think we'll reduce it to sort of 0.5 milligram per kilogram.
Okay, that's reasonable. Let's say in all of the during the patient transfer from ED up onto the ward, the child has been distressed and actually pulled out the IV. After repeated attempts at IV cannulation, so you have tried 5 times, very difficult IV access, you're unsuccessful, and the father who's attending with the child does not want you to make further attempts while the patient's awake. What do you want to do?
So I'll try to, if there's space to disclose the risk of not having an IV and then perform a gas induction, mainly focusing on the risk of the MH and the rhabdomyolysis to the father, that if we can't do an IV induction, then a gas induction would need to involve volatiles, which is a risk of precipitate dose risk.
Let's say after a good discussion and there's just no IV access at this point, and the child's not tolerating that at all, and there's just no other way to do this at the point. You do perform an inhalational induction. How do you do that for this child?
So I'll perform a SIVO with oxygen induction. So I would have ensure the dantrolene is nearby, or I know where it is or is available, because of the risk of precipitating the MH, and at least I can have an antidote to give if that happens. So I'll use SIVO oxygen, so 100% oxygen with a sort of 8% SIVO, and then titrate down. But
you perform a successful inhalation induction. And you've got the outline in, and the blood pressure suddenly reads 60/30.
So this is a crisis situation. So I'll confirm the reading of the outline, and also feel for the pulse. Potentially, this is a situation where I want to exclude life-threatening causes such as sort of anaphylaxis, cardiogenic shock, obstructive shock, those sort of any sort of tension. Well, I haven't been manipulating his airway, but tension pneumothorax still a possibility because I've been giving him some CPAP. So I'll also try to temporizing the blood pressure, giving some metaraminol, because I haven't got a central line.
You don't have a drip either.
Okay, so that would be a very tricky situation with no IV access and a hypotensive patient. In this case, I would get the IO needle ready, because if I'm not able to resuscitate him quickly, then he might further deter and go into cardiac arrest.
So are you going to do the IO or just get ready?
I would do the IO. Because he's hypotensive now to a level of, given that if the reading is true, I assume it is, then I have no other means of giving any medication or fluid or anything to support the blood pressure. Then if you go into an arrest situation, then I have no choice to put in the IO anyway.
You do the IO, and you do your best at temporizing this. What are some of the main causes of severe hypertension in a Duchenne's patient?
It could be the most likely cause in him, I suspect, would be a cardiogenic shock because of the. Sorry?
Due to what?
Due to existing cardiomyopathy, existing heart failure to a level that he decompensate because of the increased sort of drop in SVR because of the sepsis, the introduction of the anaesthetic agent that is not able to mount increased cardiac output to compensate that.
Sounds good. So what are you going to give him for this?
So with this specific cause, then I would need to give something to increase the SVR quickly. So if I got the IO in, I would give him metaraminol peripherally just to increase the SVR. Can also, if he's already tachycardic, then I can also consider giving him ephedrine, but I think the priority will be securing some central access while supporting his blood pressure.
Yeah, how much volume would you give?
I'll give another a liter of normal saline, but I think overloading him is also a risk as well if he's sort of a low ejection fraction or having any signs of right heart failure before.
Yeah. Now, in terms of you're worried about a cardiogenic issue, and you said you'd be worried about giving ephedrine because they're tachycardic. What would be your dilemma there? Because
the ephedrine will further precipitated tachycardia.
Is that dangerous for this patient?
Yeah, because it's you're actually increasing the myocardial oxygen demand at the same time.
Is that a problem in a 13-year-old?
Not in a normal 13-year-old. It's not got.
Do these 13-year-olds have more atherosclerosis or any kind of?
No, not usually. But I'm just thinking about the filling of the heart and also how effective it is if the heart rate is sort of in the 140, 150 compared to sort of 110, 120.
Let's say as you get this patient back with running some ephedrine, metaraminol, you get good fluid resus, you manage to secure a central line with a 4-lumen access, and now you've got to a state of stability. And you notice that the urine is quite brown. What's going on?
Now, because I've given a gas induction with a volatile agent, and there are signs of rhabdomyolysis given the dark urine, I think that's a high possibility. I also want to do a core temperature just to ensure.
Temperature is 36.
36, okay, because I want to exclude any signs of MH as well. So one I've got stability, I will switch this patient back to TIVA because I want to remove the trigger agent, which is the volatile agent. I also want to get my assistant to prepare a fresh anesthetic machine with a fresh circuit just to remove any other volatile.
Is that part of the recommendations to change your anesthetic machine for MH?
Not really, but I think it would be. I just want to ensure any traces of the volatile is removed.
What is recommended for MH?
They recommended they put in activated charcoal filter. They asked just to flush the circuits with high flow.
Okay. What are your other management aims with rhabdomyolysis?
And the other management will mainly be supportive, i.e. adequate hydration, ensure a adequate urine output to sort of 1 to 2 mils per kilo. In this case would be about sort of at least 100 mils per hour, and maintain a good central venous pressure, i.e. ensure that well filled. In this case would be sort of around 12 to 16 centimeter of water. I can give sodium bicarb as well to ensure the urine alkalization will help the excretion of the myoglobin. And obviously, I already mentioned removing the triggering agent, which is the volatile agent.
Anything else as part of management?
The other management will be sort of post-operatively.
Anything you're concerned about once they have rhabdo that you'll be checking?
The hypokalemia.
What's the treatment for that?
So the first line would be giving calcium gluconate 10%, 10 mils slowly as a slow IV push. We'll look at the cardiac monitors to see any signs of hypokalemia waveform, or the T wave and the QRS complexes. To treat the hypokalemia itself, I'll also give 10 units of rapid insulin in 50% glucose in 50 mils, and then give it over 20 minutes, monitoring his blood sugar with the blood gas and the potassium with the blood gas. The other agent that I can consider will be nebulized salbutamol, but usually those 2 lines of treatment will be able to temporarily bring down the potassium.
Right. And anything else? Any other agent you can use?
You can give sodium bicarb.
Beautiful. We'll end the Viva there. Hey, well done, Ralph. That was really great. First of all, how do you feel?
I feel generally okay. I think sometimes the way I written the thing is a bit disorganized. But you can see it. I think I can do with using that 90 seconds a bit better. I actually wrote down scoliosis, and then when you prompt me, what other things involve respiratory, and I will actually, looking back into the keywords I wrote down. I think it's tricky to wanting to say the answer and then balancing and take a step back and actually have a think about what you're going to say.
Absolutely. Hey, so Ralph, I think you did really well. Now, you notice how rapidly I was moving through things. I've observed the exam. I feel like I'm trying to forge a path that some examiners like this, some aren't. So hopefully it's similar to some of the examiners. They're all quite different, I find.
Yeah, sure.
And so just from the start, just to let the audience know, like this is a really tricky vibe. It's Duchenne's muscular dystrophy. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.